Hello and welcome to this second part of our four-part series on integration of non-communicable disease care into HIV care. Once again, my name is Patrick and I'll be glad to take you through as we discuss hypertension care, screening and management, and how we can integrate these into HIV services. Once again, this is an CME, continuing medical education. It is meant to empower everyone with knowledge about these conditions so that we can better serve those under our care. For hypertension, when we talk about it, what do we refer to? Hypertension basically means high blood pressure. And if we're to explain what that means, it means somebody having a persistently high resting blood pressure, meaning they have to be seated, they have to be calm. And when you take their blood pressure reading, it's above 140/90 on two measurements, at least minimum of two measurements taken 5 minutes apart, or on at least 2 or 3 occasions at 1 week intervals. So we don't take one blood pressure reading and conclude that somebody is hypertensive. No, we have to take several readings and then conclude that because it's persistently high, when this person is at rest, they have high blood pressure. And we use the cutoff of 140 systolic reading over 90 diastolic reading. And why is hypertension important? Because it predisposes to so many risk other diseases like stroke. It can cause stroke, it can cause heart attack, kidney disease, eye complications, sexual dysfunction, among others. How does it cause this? So when you have blood vessels through which your blood is flowing, especially the tiny ones, if the pressure is so high, they can rupture under high pressure, and in so doing, they can destroy the brain, they can destroy the retina in the eye, cause eye problems, they can cause kidney disease, they can also cause heart attack because the heart is supplied by tiny coronary vessels. So those ones can also rupture and somebody gets a heart attack, or it can also predispose to clotting events and somebody gets a tiny clot that blocks off blood supply to part of the heart, part of the brain, part of the eye, and cause problems. So persons with HIV are at a higher risk of hypertension. One, they are taking medications that are metabolized and cleared through the kidneys, and they can also cause some damage in the process. We know, for instance, that tenofovir can cause kidney disease as a side effect, a condition we call Fanconi syndrome. But we also know that HIV itself can cause HIV-associated nephropathy. What that means, HIV damages organs. HIV can affect the heart, can affect the kidneys, and in so doing, lead to problems with blood pressure. So how do we screen for hypertension? It's important that we screen to prevent those complications I've talked about: stroke, heart attack, eye complications, kidney complications, heart failure. The heart, as it continues pumping against high pressure peripherally, the heart itself can undergo damage in the process, so you can end up with heart failure. We screen adults mostly for hypertension, 18 and above, adults aged 18 years and above, and we screen at every clinic visit. How do we screen? We use a blood pressure machine to screen for hypertension. We just take your blood pressure reading when you're seated and calm. What do we aim for when we are managing, when we are screening? We aim for an accurate blood pressure measurement, and we have to document the reading. As I mentioned, when we are screening, we use a blood pressure machine. The subject has to be seated down, calm, and we also need a seat with a firm back support and the blue card on which we shall document our reading. So the subject has to be seated with the back supported, then the arm placed at the table surface at the same level with the heart, and then we put the cuff about 3 centimeters above the elbow joint, and we have to use the right size of the cuff. Most of the cuffs we have are for adults, the blood pressure cuff that we tie here. And then we press the start button on the digital BP machine and wait. If the reading is high, we repeat this measurement 2 or 3 times with 3-minute intervals, or we can even repeat it after 1 week to see if it is still high, and we record the lowest reading. Now, we have to be aware that there is a type of hypertension we call white coat hypertension. Some people, when someone's blood pressure is being taken, they become anxious, they become excited, and that anxiety or excitement can cause their blood pressure to rise. So they will not be resting, they will not be calm. And it's important that we take these blood pressure readings when people are calm. So that white coat, they're fearing the white coat of the doctor or the nurse who's taking the reading. That's why we have to do multiple readings to draw a conclusion in making the diagnosis. And you may ask, what causes hypertension? We don't know. In most cases, for most people, the cause is not known, and we call that essential hypertension. But for those where the cause is known, maybe somebody is taking medications that predispose them to high blood pressure. Maybe someone has thyroid disease causing hyperactive thyroid that causes their blood vessels to constrict and their heart to race, then the blood pressure goes up. So that, in that case where there is a known cause, we call that secondary hypertension. For the majority of cases, it's essential hypertension. We may not be able to point at a specific cause. So the diagnosis of hypertension is made when the systolic reading is above 140 and above, and the diastolic reading is 90 and above. On 2 occasions, at least 5 minutes or 3 to 5 minutes apart, or at an interval of 1 week. But we don't take, important case in point, we don't take one reading. We have to take several readings to conclude that someone is hypertensive. But we also know that sometimes we get patients who are already on antihypertensive medication. So these are known hypertensive patients. So you might take the reading, but it reads normal blood pressure, because they are already on medication. They are still hypertensive patients on medication. If you stop the medication, the blood pressure will shoot up. So the American Heart Association has classified the blood pressure readings, 2 categories, based on the reading. The normal blood pressure ranges from 90/60 to 120/80, in that range, 90/60 to 120/80. Anything less than 90/60 is hypotension, low blood pressure. And then when you start going above 120/80, we say it's elevated when it's 120 to 129 systolic, but it's still less than 80 diastolic. Then if it goes higher from 130 to 139 systolic, and then diastolic 80 to 89, that's stage 1, which would refer to as hypertension. In some grading systems, a reading from 120 to 139, we would call that pre-hypertension. 120 to 139 over 80 to 89, we would call that pre-hypertension. So stage 1, those are the readings, and then stage 2, it goes higher. Above 140 systolic, above 90 diastolic. This is according to the American Heart Association grading. And then hypertensive crisis is very high. Systolic above 180, diastolic above 120. A hypertensive crisis is an emergency. In some literature, you find them talking about malignant hypertension, very high blood pressure readings, which cause organ damage. For example, at such readings of blood pressure, the tiny blood vessels in the retina of the eye will rupture, and somebody ends up with eye complications, which you can only see if you do what we call fundoscopy uh, or ophthalmoscopy. A fundoscope, ophthalmoscope, is used to look at the retina in the eye. So when we look there, we can see what's happening to those tiny blood vessels, and we know that there's some damage, and there are some characteristic features we look for. So very high blood pressure readings are the ones increasing the risk for rupturing blood vessels in the brain, causing heart attacks, kidneys. The kidney blood filter is also damaged, so end up with kidney failure and so forth. And it's an emergency. We need to consult physicians while managing hypertensive crisis. So we all know what we should do to avoid having high blood pressure. We keep telling people to stop smoking, have physical activity regularly, at least 30 minutes per day. We sit in the offices, then we sit in traffic jam, we get home, we turn on the TV and watch TV seated. There is no time for jogging, no time for walking. Let's have some exertion for at least 30 minutes. That helps to control your weight, especially when we've been having an unhealthy diet. So we must eat healthy, a diet rich in fruits and vegetables, low in fat. Limit processed foods, avoid them if you can. Processed foods, these canned drinks, bottled drinks. We have so many juices on the market, sodas, all these processed juices. No, let's eat organic and reduce refined sugar intake, but also reduce salt intake at the same time to less than 1.5 grams per day. Control your weight. If you stand on the weighing scale, measure your height, you can calculate your BMI, body mass index. The normal one is 18 to 25 kilograms per square meter. If you have a very high BMI above 30, you're obese, and you need to do something about your weight. Waist circumference of less than 82 centimeters for females and less than 102 centimeters for males is normal, but some of us have very big waist circumferences. You pinch on your waist and you see a lot of trunk or fat. Your waist is very big, so you have to watch your waist circumference and your body weight. Avoid harmful use of alcohol. So let's try to watch what we eat and be physically active, control our weights and our lifestyles. On this list, what's missing? Get enough sleep. Sleep also has an effect on blood pressure control. You don't sleep enough, your blood pressures will tend to go up. So this is a healthy eating plate, what our healthy plate should look like. Have big proportion of vegetables, have whole grains, fruits, healthy oils, and drink enough water. Healthy oils, when you're cooking, use oils like olive oil, canola oil on salad, take plenty of water, um, and more proteins. But most of our plates may not look necessarily like that. We need to revise, and this is a wake-up call. So this is a plate looking at, again, what we should be eating. Half of the plate should be vegetables. A quarter of it should be proteins. You see some chicken here. And a quarter, starch, rice, and with water. At least 3 liters of water per day. Now, if you look at some of our plates, we have posho, there's big matoke, and rice. There's no vegetable. The vegetables, if they give us some vegetables, it's just a pinch of dodo or a pinch of, nakati, sukuma wiki. Very, very little. Yet the vegetables should be the bulk of the plate. So we always, in most cases, serve in the reverse. We end up taking in more starch than anything. So this is a wake-up call for us as we control risk factors for hypertension. Danger signs, I talked about what hypertension does. Now, sometimes when somebody is going into a complication of hypertension, maybe they're getting a stroke, they're getting a heart attack, or their eyes are going to be affected, they're getting the symptoms of complicated hypertension with end organ damage. There are some symptoms we can look out for. Someone with a heart attack or who's getting a heart attack will complain of chest pain, heavy, tight squeezing chest pain. The pain radiates to the left shoulder, upper arm, referred pain to those parts. But this pain can be associated with breathlessness, difficulty in breathing, at rest or on exertion, depending on the level. We call that angina. And this person is getting, in medical terms, what we call a myocardial infarct or a heart attack in simple terms. They might get unilateral body weakness when they're getting a stroke, usually preceded with headache and other symptoms like slurred speech. They might get lightheadedness. And in some cases, before the strokes happen, people tend to get transient ischemic episodes. A tiny blood vessel gets blocked and then unblocked. So some of those symptoms, brain damage happening as a result of high blood pressure, the tiny blood vessels in the brain being affected, either they rupture or they clog with a clot. The person might present with weakness. You tell them to lift their arm and they can't. And sometimes there's a sudden collapse, severe headache. And headaches, by the way, are a common symptom of high blood pressure. When someone complains of headache, there are many things that can cause headache, including stress, hunger, dehydration. But one of them we should not forget is to take the blood pressure reading. Headache can come from lack of enough sleep, can come from so many things, migraines, but high blood pressure is one of the causes of headache. So let's always remember to take a blood pressure reading when someone complains of headache, if we would like to rule it out. The danger signs continued. In malignant hypertension, blood pressure readings are very high, 180 over 110, and there's end organ damage. When you measure the pulse rate, it might be too low, less than 60, or too high, more than 120. The normal pulse rate is 60 to 100. Estimated glomerular filtration rate of less than 30 mils per minute per 1.73 square meters. The glomerular filtration rate refers to the kidneys, how they filter the blood to create urine. So there's a rate at which the blood should flow through that filter as urine is being formed. The normal glomerular filtration rate should be above 90 mils per minute, 90 mils of blood filtered per minute per 1.73 square meters. That 1.73 square meters refers to the body surface area. So if we take your body of an adult and we lay it flat on the floor, it covers an area of 1.73 square meters. So we use it to standardize the GFR, glomerular filtration rate estimated, eGFR, is usually measured against a standardization unit of the body's surface area. Now, because the kidneys are not filtering well, in high blood pressure, the filtration rate drops to less than 30. From 90 to, imagine, it's dropping to less than 30, meaning that the kidneys are not efficient. They're becoming less efficient at filtering your blood to form urine because there is damage that has been caused by high pressure affecting those blood vessels at the glomerulus, which is the part of the kidney where that filtration takes place. Now, around the glomerulus, the kidneys are very important in blood pressure control, and I'll come to that. But there's a lot that happens at the level of the kidneys. So if the EGFR falls below 30 mils per minute per 1.73 square meters, there's a problem with the kidneys. Similarly, because filtration is not happening enough, your potassium levels might either go very low when you're losing a lot of potassium or rise to above 6. The normal range of potassium in blood is 3.6 to 5. 3.6 to 5. So less than 2.5 or above 6, you're having very low or very high potassium. And there are also drugs that can affect potassium levels, drugs which we use to treat hypertension. So we have to tie all these things together. Sodium can also become too low or too high. The normal sodium is 137 to 145 millimoles per liter. So if the filtration is happening a lot and you're losing a lot of sodium, your blood sodium levels will go down to less than 120. And if your filter is again damaged and you're filtering less, you're retaining a lot of sodium. When we measure your serum sodium levels, they are high, above 150, danger sign. We call that hypernatremia, high sodium. If it's low, hyponatremia. Then if someone less than 30 has uncontrolled blood pressure, again, it's a danger sign. So when somebody is getting a stroke, we have this acronym called FAST, where you look at the face. F is face. You can ask them to smile, and you'll notice that the smile is not symmetrical. It's not a symmetrical smile. It is asymmetrical. Smile. Only one side of their face is smiling. So there's a problem. Some of the nerves have been damaged, probably by the stroke. You tell them to lift their arms. The A is arms. They can't lift their arm. The S is speech. You tell them, say, sweet potato. And they say, so they cannot articulate the word potato. So there's a problem. They have slurred speech. And then if you tell them, you give them those commands and they are not doing them properly, sometimes there's even confusion. Someone is not understanding at that point. Then the T, you have to quickly call for help. Call emergency services or call your colleagues. Shout for help. Shout for help and people to come and rescue this person who's having a stroke. There's mini strokes which I talked about called transient ischemic attacks or transient ischemic episodes. And those come and go. Someone gets a mini stroke and then they improve. But we have to act fast. So this algorithm shows us how to screen and manage for hypertension and manage hypertension. Screen for hypertension, we talked about blood pressure measurements. They have to be taken at all encounters. With their risk factors we ask for hypertension, and we shall give you those screening forms where you can take a brief history of the risk factors of hypertension. They include age, they include lifestyle, obesity, smoking, family history of hypertension, the number of risk factors for hypertension, and even some medications can predispose to hypertension. Then we have to take the blood pressure measurement at every visit. If it's less than 140/90, we don't panic, we continue monitoring. We advise on lifestyle changes. But if the blood pressure is above 140/90, then we look at risk factors as well. If it is from 140 to 159/90 to 99, with less than 3 risk factors, there is no organ damage or complications, we advise on lifestyle modifications. We review after 3 to 6 months. And if still the BP is not controlled by lifestyle modifications, we tell the person, sleep enough, reduce your weight, do physical activity, stop smoking, we reduce the risk factors, and we tell the person to come back after 3 months. The blood pressure is not controlled by lifestyle modifications. We then introduce hypertensive, antihypertensive drugs. We introduce one drug first. In most cases, we start with a calcium channel blocker. We shall see the drugs that we treat hypertension with. So we combine lifestyle modification with monotherapy, one drug, and then we review after 1 month or 4 to 6 weeks. If still the blood pressure is not controlled, we then introduce a second drug. So the person is going to be on at least 2 drugs plus lifestyle modification. Most of these drugs, FDCs, fixed dose combinations to make it easier for patients to swallow. So once we've introduced 2 drugs plus lifestyle modifications continuing, after 1 month we schedule an appointment, we take the blood pressure reading again. If it is still not controlled, we might be forced to add a third drug or adjust the doses of the 2 drugs we introduced. We might increase the doses so that we achieve the control of blood pressure. However, there are some blood pressure readings. If somebody has 140 to 159 systolic, 90 to 99 diastolic, with more than 3 risk factors, straight away we introduce lifestyle modifications plus monotherapy, and then we continue monitoring. If it's still uncontrolled, we do dual therapy. We add another drug. There are now 2 drugs, preferably fixed dose combination. If there's still no control after a month, a third drug, triple therapy, preferably fixed dose combinations, plus continuing the lifestyle modifications. You notice that lifestyle modification is continuous. That counseling has to be done continuously until we achieve the desired level of control. So we introduce one drug at a time or adjust the doses of the already existing drugs that the patient is on. And we have to keep monitoring for end organ damage. I talked about the eyes, I talked about the brain, the heart, the kidneys. Now, we also, if someone has blood pressure above 160 over 100, straight away we go to at least 2 drugs with lifestyle modifications, and we review after a month. Now, let's talk about the drugs used to treat high blood pressure. These drugs work at different levels. There are those that work on the brain, there are those that work on the heart, those that work at the level of the blood vessels themselves, and the kidneys. So let me just talk about blood pressure before I go into the drugs in detail. So blood pressure control in the body there are a number of systems involved. The brain is involved. There's a pituitary gland in the brain which releases some hormones. There's the antidiuretic hormone. Those hormones play a role in what we call the renin-angiotensin system, which coordinates with the kidneys. So when the kidneys detect low blood pressure, around the glomerulus, you remember the filter I talked about where the filtration of blood to form urine is happening? Around there, we have some special cells called juxtaglomerular cells, which release a hormone called renin. Renin is supposed to convert another hormone called angiotensinogen to angiotensin 1. And angiotensin 1 gets converted to its active form, angiotensin 2, which causes the blood vessels to narrow. When blood vessels narrow, think about a pipe. If water is going through a pipe and you make it narrow, what happens to the pressure? The pressure goes up. So when the body notices low blood pressure, those hormones are released and they eventually cause the blood vessels to constrict. Constricting means narrowing, so that the blood pressure goes up. And the other hormones from the brain, from the pituitary gland, also will stop your body from passing a lot of urine, the antidiuretic hormone. Antidiuretic. Diuresis means urinating. So anti means against urinating. That hormone will stop you from urinating so that you retain water and your blood pressure goes up. At the same time, there are some hormones which will be working on the heart to increase the heart rate so that the pressure goes up. So you see that the whole system is working together to bring the blood pressure up. And this happens if those cells detect that your blood pressure has dropped. So the body keeps working like that, using those signals to keep your blood pressure within a normal range. Now, these drugs which are going to bring down your blood pressure, if your blood pressure is abnormally high, above 140/90, these drugs act at these different points. There are those which act centrally, like methyl dopa, clonidine, and others which work at the level of the brain. Then there are those which work on the heart. We call those calcium channel blockers. We also have beta receptor blockers so that the heart doesn't pump fast. And we have those which work on the blood vessels to widen them so that the pressure drops. And then there are those which block that renin system. They are called angiotensin converting enzyme inhibitors. So angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, which constricts vessels. So if you inhibit that enzyme, the vessels won't constrict. They will remain wide and the blood pressure will drop. Then you have angiotensin receptor blockers. Also, those act on the renin-angiotensin system. And then you have diuretics, which make you urinate a lot so that you lose water and your blood pressure comes down. The beta blockers and alpha blockers work on the heart. So these are the antihypertensive drugs. Once you understand the system of how blood pressure is controlled in the body, you can understand how these drugs work. They act at different stages. So calcium channel blockers include drugs like amlodipine, nifedipine. You've seen them on the market. Angiotensin receptor blockers include, we usually call them ARBs, losartan, valsartan, irbesartan. Here they all end similarly with tan, losartan, valsartan, irbesartan. Then angiotensin converting enzyme or ACE inhibitors include captopril, lisinopril, ramipril, fosinopril, and others, pril. Diuretics, we have different types. There are those called thiazide diuretics, and we also have among the thiazide diuretics like bendroflumethiazide, hydrochlorothiazide. Then you have the loop diuretics like furosemide. Those are usually referred to as high ceiling. Then the potassium sparing diuretics like spironolactone. These just make you urinate a lot so that you lose water and the blood pressure drops. That's how they bring down the high blood pressure. Then the beta receptor blockers like atenolol, carvedilol, propranolol, they end with olol. Those work on the heart, block the beta receptors, and in so doing, they slow down the heart. And then alpha blockers like prazosin. Drugs that work on the heart slow down the heart, and then there are those that dilate the vessels. So the blood pressure is actually a product of what we call cardiac output and peripheral vascular resistance. Cardiac output is what the heart pumps out and how strong the heart is pumping. Then the peripheral vascular resistance is affected by the constricting or the dilating of the blood vessels throughout your body. When your blood vessels constrict or narrow, the blood pressure, the resistance goes up, so the blood pressure will also go up. When they dilate, the resistance to blood flow reduces. The blood can flow through freely. Therefore, the blood pressure will drop. And that is a short lecture on how blood pressure is controlled in the body. So, in our treatment protocol, remember we're introducing one drug at a time, but lifestyle modifications as a must. So the first drugs we usually introduce, we introduce amlodipine. It's a calcium channel blocker, preferred drug to start with in monotherapy. Amlodipine, 5 milligrams. Now, if somebody still is not controlled, let's look at this column and follow the steps. These are alternatives, and these are second alternatives. So if someone is not controlled by lifestyle modifications plus amlodipine alone, we introduce valsartan, which is an angiotensin receptor blocker, ARB. So we introduce valsartan 80, amlodipine 5, preferably a fixed dose combination. If still there is no response after 1 month, after 4 weeks, we can increase the dose of the amlodipine to 10 milligrams, keep the valsartan at 80 milligrams. The alternative is to use, if you don't have valsartan, you can use losartan. So we first increase the dose of the amlodipine. We double the dose actually to 10. If still after 1 month there is still no control of the blood pressure to less than 140/90, we now double the dose of the valsartan from 80 to 160. Or if you're using losartan, you double the dose from 25 milligrams to 50. Then if still after 1 month there is still no control, we might be forced to introduce a third drug on top of the amlodipine, the valsartan, and we add hydrochlorothiazide. Now we're introducing a thiazide diuretic into the picture at 12.5 milligrams for hydrochlorothiazide. Luckily, there are drugs fixed dose combinations on the market where you find all these three drugs in one tablet. For those who are taking losartan, again, we can have amlodipine 10, losartan 50 with hydrochlorothiazide 12.5 as triple therapy plus lifestyle modifications, remember. So all these treatments can be given at health center 3s, except when we're using triple drugs, where we recommend starting from health center 4 upwards. If someone is still not controlled by that stage, preferably we want them to be managed at a health center 4 upwards if you're introducing a third drug. So what are the side effects of these drugs? These antihypertensives have side effects. The calcium channel blockers, amlodipine, nifedipine, usually cause lower limb swelling or lower limb edema. And about 1 to 10% of people taking, they can cause headaches. Someone complains of headache, palpitations, erectile dysfunction, and muscle cramps. So if someone has edema, lower limb edema, we observe, we consider introducing an alternative medicine. We might replace the amlodipine with something else. And if excessive, if the edema is excessive, introduce a diuretic. And if the diuretic doesn't help the edema to go down, you might want to switch or to change from the amlodipine to another drug, another antihypertensive. Headaches and palpitations are usually self-limiting. Erectile dysfunction is very important. If somebody is complaining of that, you might consider looking for other causes of the erectile dysfunction or stopping the amlodipine or nifedipine and introducing another antihypertensive, replacing with another antihypertensive. Muscle cramps are usually self-limiting, we observe. For the angiotensin receptor blockers, valsartan and losartan, they cause low blood pressure, hypotension with dizziness in 10% of those taking them. They can cause high potassium, hyperkalemia in 4 to 10%. They can also cause angioedema, though it's rare. It shows commonly as swelling in the lips, and in that case, we have to stop the angiotensin receptor blocker if you have angioedema. For hyperkalemia, we have to keep monitoring the potassium levels. We stop the drug if the potassium is above 5.5 millimoles per liter, or if the eGFR, remember we talked about the estimated glomerular filtration rate, if it drops to below 30 mils per minute per 1.73 square meters. Then for hypotension, that's again risky. If the hypotension drops to less than 100, you have to reduce the dose and keep monitoring the blood pressure. Reduce the dose of the angiotensin receptor blocker. Captopril, an ACE inhibitor, angiotensin converting enzyme inhibitor, can cause hyperkalemia, pruritus, which is itching, and they're also notorious for causing cough in 1 to 2% of people taking captopril. For hyperkalemia, again, potassium, when it's high, we have to stop if the potassium is very high, above 5.5 millimoles per liter, or the eGFR less than 30 mils per minute per 1.73 square meters. Then for pruritus, itching is usually self-limiting, observe, reassure. And for hydrochlorothiazide, these thiazide diuretics, they are notorious for causing high uric acid levels, hyperuricemia, high fat levels, hyperlipidemia, high calcium, and photosensitivity. Someone is sensitive to light. We just monitor these levels in blood. We monitor the uric acid, do a lipid profile, monitor the calcium, and if someone has gout, preferably get them off the hydrochlorothiazide, put them on alternative antihypertensives, because uric acid going up will worsen the gout, and also advise on diet modification. Yes, so we're towards the end. Um, Interactions with ARVs. How do antihypertensive drugs interact with ARVs? Now, remember, this is an HIV patient taking ARVs, and they're also going to be put on antihypertensives. Now, if you put them on calcium channel blockers like amlodipine and nifedipine, and they're taking NNRTIs, efavirenz, nevirapine, these NNRTIs are known to stimulate the liver. They stimulate an enzyme system in the liver called the cytochrome P450 enzyme system. That enzyme system in the liver clears drugs. It's responsible for metabolizing drugs. So when the liver is stimulated and someone is taking nevirapine, efavirenz, the liver has been stimulated by those drugs. These antihypertensives, amlodipine and nifedipine, will be cleared very quickly, so their drug levels will reduce in in circulation. So someone's blood pressure may not be controlled well, although we don't. There's no dose adjustments required, but you should be mindful that the NNRTIs affect calcium channel blockers by reducing the plasma levels of calcium channel blockers due to increased or activation of the cytochrome P450 liver enzyme system that clears drugs from circulation. Then for the PIs, lopinavir, ritonavir, atazanavir, ritonavir, darunavir, ritonavir, these PIs do the opposite. For them, they block the cytochrome P450 enzyme system. So by blocking that enzyme system, it means drugs are not going to be cleared from the system. So PIs have the reverse. Instead, for them, they will increase plasma levels of calcium channel blockers. And in that case, we have to be very conscious with nifedipine especially. Someone can end up with very low blood pressure due to sustained high levels of nifedipine in circulation. It's not being cleared. So we need to monitor, especially if someone is on nifedipine, monitor the blood pressure. If they are on a PI, like lopinavir, ritonavir, boosted atazanavir, plus nifedipine. So losartan interacts, again, efavirenz for losartan. Efavirenz may reduce formation of the active form of losartan, hence reducing the efficacy of losartan, but we don't recommend any dose adjustments, though we should be mindful of that interaction. The PIs reduce elimination of losartan. Remember, PIs inhibit or they block the cytochrome P450 enzyme system. So drugs are not being cleared, including losartan. Losartan is not being cleared. So anyone on PIs, remember, PIs are blocking the liver enzyme system that is supposed to clear drugs or metabolize drugs out of the system. So if you block that system, the drugs like the losartan, the nifedipines, those drug levels will remain high in blood because they are not being cleared. And therefore, someone's blood pressure may drop significantly. And we should use with caution, especially in patients with liver disease, hepatic impairment. Valsartan, ACE inhibitors, and all diuretics, including the hydrochlorothiazide, bendroflumethiazide, all the other angiotensin receptor blockers except losartan and ibesartan, and all ACE inhibitors, including captopril, have no drug interactions with ARVs. And there's nothing we should do. The good thing, these drugs are safe. There's no drug-drug interaction with ARVs. So the only drugs you should be mindful of, the antihypertensives, should be mindful of nifedipine, especially be mindful of losartan, ibesartan, and be mindful of captopril. So as I conclude, how do we monitor treatment? When someone starts the antihypertensives, we have to keep doing monitoring checks while they're on treatment. At 6 months, we check blood sugar because they tend also to develop. There's a close link with diabetes. So do a fasting blood sugar at least every 6 months, a urine protein. Urine protein checks the kidneys. If the kidneys are leaking proteins in urine, there's a problem. Your urine is not supposed to have protein in it. So if we find protein in urine, it means your kidneys are being damaged by probably the high blood pressure is now having end organ damage. So we need to check a urine protein again. Potassium and sodium levels, check them to see how the kidneys are working. But also remember the side effects of some of these antihypertensives, the diuretics and the ACE inhibitors and the angiotensin receptor blockers can affect sodium and potassium levels. And the creatinine again, if someone is on an ACE inhibitor or an ARB. Every year, 12 monthly, do a lipid profile. Every 2 years, check the heart, do an ECG, electrocardiogram, and also do fundoscopy, use an ophthalmoscope, look at the retina in the eye, look at those tiny blood vessels in the retina to see if they've been damaged by the high blood pressure. And again, we keep routine monitoring. For anyone with no symptoms, we have to keep monitoring, check their blood pressure to make sure it is controlled. So important, as in a nutshell, we have to check while someone is on treatment at regular intervals. We check how are the kidneys, how is the heart, how are the eyes, how is the brain, these organs that would be affected by the high blood pressure, how are they? So we keep monitoring those, and those are the tests that we do. For someone who is on antihypertensives and ARVs, the goal is to achieve blood pressure less than 140/90 and to suppress HIV virus. We have to monitor complications of uncontrolled hypertension. We have to assure patients that treatment for high blood pressure is lifelong. Treatment for HIV is lifelong. Hypertension often has no symptoms, so beware about that. Both ARVs and antihypertensive drugs can be swallowed at the same time. Maintain lifestyle modification for HIV, lifestyle modification for high blood pressure, reduce risks with treatment, adhere to the ARVs, and also adherence to ARVs helps to reduce complications of HIV infection in the blood vessels. So remember that while we are dealing with high blood pressure affecting all these organs, all these blood vessels, HIV is also there. It can also cause damage on the blood vessels and on the organs. So we have to think about that dual damage that can result from this comorbidity. And then explain the side effects of all drugs, the drugs that the patient is taking, so that they don't come as a surprise. What should you do as a health worker? Make sure that at triage, all people coming have a blood pressure taken. Remember how we take the blood pressure. And when you're giving health talks, integrate information about high blood pressure. Document on the blue card, update records in the electronic medical record systems, EMR. Encourage adherence to ARVs and antihypertensives, and report data on the people you've screened for hypertension, how many were screened positive for hypertension, and how many were managed. So that brings us to the end of hypertension. It's been a nice 48 minutes, but I've tried to go a bit deeper to simplify it and make it easy for everybody to understand. So once again, thank you for your attention. It's been long 48 minutes. You've been with me through this all. I hope it's been helpful, but as a parting shot, make sure you have your blood pressure checked today. So everyone who comes to our clinics, regardless of whether it's the HIV clinic, whether it's the OPD, any department, make sure we check the blood pressure. It's a silent killer, can have no symptoms while causing damage in the background. I want to thank you for this. I'll see you in the next one when we'll talk about diabetes mellitus and obesity. That's it for now. Have a good day. Bye-bye.